So welcome to NUR203 Exam 2 Review. Know that even before some of your professors get it posted to your announcements, remember I have a YouTube channel, Professor Bogart, Pediatric Nursing, and I usually have it up within 20 minutes. As soon as the recording comes up, it's on my YouTube channel. So that's the first thing that I take care of. So you can get it even before your professor send it to you. Just giving you a little hint and a little help. So let's go ahead and let's start. So I know I love pictures, and pictures do tell you 1,000 stories. And I think every picture here is going to be part of the exam. A scared child, being honest about them and pain, etc. You're cognitively delayed. Let's talk about those down kids a little bit. Respiratory, cardiac, and cystic fibrosis and chest PT. I mean, the pictures tell you a lot there. So anybody who's not going to take the exam in class, going to do it on campus, you have to notify that instructor. And that person who's going to tutor you, proctor you on campus, must email the professor, because that gives us the okay, that is somebody who we can share the access code with, and we can give them the code. Okay, very important that that's done like that. So beginning, let's start with eye issues. So amblyopia, call it a lazy eye. A lazy eye, the muscle don't work. So what is our big thing here? Well, muscle doesn't work, so the eye can be up, down, inward, outwards, and it's just like you're looking at them and you're like, where do I look at, right? It could be that sort of thing. So if a muscle is weak, how do you fix it? You make it work. So cover the good eye, make that bad eye work. And they put a patch on, and they do it a couple times a day. It all depends on the physician, but we're going to make it exercise. Now, strabismus is also called cross-eyed. Your eyes are trying to focus on an object, but they go past each other. So it looks like you're cross-eyed. So the eyes cross at midpoint. That's the key words, cross-eyed. And it could be sometimes, or it could be all the time. Again, this is more of muscle training, etc., that will help them. Now, cognitive impairment. So this is a child, it could be Down's child, could be autistic, even factor X is part of them. But early cognitive impairment, what would you see? Well, in a child who, like Downs, they are going to have different looks to them, whether it is in their face, bridge of their nose, their tongues. It could be anything that will clue you into, okay, this could be a Downs or a cognitively delayed child, right? That's the first thing. These children get irritable for no reason, many times because they can't tell you what they want. They don't know how to express it. So they are irritable and get behavioral difficulties because of it. They do not respond to the environment around them. They're playing, they're sitting there in their corner, and they don't, what's ever going on around them, they don't mind, okay? You're going to see things like gross motor delays, fine motor delays, and they're not going to be having the speech that a normal child would have. At 1 year, you should be able to say mama, dada, milks, nana, pop, whatever it is, right? And of course, as I said, those behavior, because they can't express themselves, and they're not going to be meeting the milestones, turning over when they should, sitting up when they should, walking when they should. They're going to be delayed. Now, the biggest cognitive of all of them syndrome is Down syndrome. We do have those stubby, short little fingers and toes. The palate in the mouth is really high. They've got this big tongue that you notice, a Down's child, their tongue usually sticks out. They've got big almond-shaped eyes, and they're very hypotonic, which means they can take both legs and put them behind their neck. I mean, they're just so flexible. That's what that means. These children are apt to have cardiac defects, VSD, AV canal, truncus. You don't have to know the other two, but there are cardiac conditions, the VSD they could have. Also, we don't realize this, and it was actually a HESI question that I saw, that these children are at higher risk for leukemia, and also we need to monitor them for hypothyroidism. So that gives you a couple extra things we have to look at. We know that there's this semian or palmar crease. It's like right across. Usually, if you're in doubt, pick up the hands, feet, and you can see the crease across their palms. There's like a big space between their toes and their thumbs. It's normal. And the other thing is their nose is flat and sort of indents. It's called an underdeveloped nasal bone. And what happens, mucus gets caught in there, drips on the airway, and causes respiratory infections. And that's how it happens. Now, these children are special when they have to be in a hospital. They are high stress, high anxiety, especially when they're away from their mommies and daddies or caregivers. So if they have to be, make sure that we have the same staff taking care of those children as much as possible. And we encourage parents to stay there and again, stay on the same routines, okay? This does definitely, you can do a lot to these kids. They're lovable, but as long as their parents are around. Now, autistic children. These are, of course, they're a cognitive delayed child, but a little bit more than that. These children don't look at you in the eye. They don't, when you call them, they just sort of ignore you. They don't even, as infants, try to imitate behaviors. I was telling my class, you could take an infant, a normal, healthy child, stick your tongue out at an infant, and they're going to try to stick your tongue back at you. A child who's autistic as they get older aren't going to be doing those things. They won't. They also have what we call unusual repetitive behaviors. I was watching this one little boy, autistic kid, who would take and come in to his, daycare, would sit in the corner when he was done with what he had to do, because he has a routine. He knew how to get his vitals first, sit in the corner, and he would take toys. And he would take one and put on top of another, and another on top of another, and then he would take it off and put it down. Take it off, put it down. Then it would put it back up, and then the other one, put it up. It's over and over. This is very soothing for them. They love to play alone. They don't know how to share. They don't understand that. Also, they don't like certain textures, like sometimes foods, whether it's too thin or too thick or too chunky, whatever. It's a texture they don't like. They don't like loud noise. They don't like bright lights. And we know usually autism, we do not diagnose till they're 2. Now, are they going to have some sort of, possibilities before that? Oh, absolutely. But they don't give them that diagnosis till they're about 2. And remember, any kid, autistic, cognitively delayed, make sure your biggest priority with having them play in toys, safety. These children don't know that they can fall and hurt themselves. They don't know the toys, they put it in the mouth, will swallow it and choke. They just don't understand. So safety, safety, safety. Now, verbal milestones, early interventions, talking about speech. Well, by 2 months, they should be cooing, right? Making a sound like something. 4 months, they're laughing and gurgling and cooing. By 8 months, now they're what you just did a noise, they're going to try to imitate it. By 10 months, they know when they reach for something they shouldn't, and you say no. Oh, I know what that means. They understand simple commands. And as I said, by 10 months, by a year at the latest, they should be saying 2-syllable words like mama, dada, okay? And by 1 year, they're going to have 3 to 5 different words. Mama, dada, nana, pop, pop, milk, whatever it is, okay? So infants should be a part of their tummy times and, parents sitting with them is they need to be exposed to all sorts of sounds, okay? Now, if we have an infant who's not doing these things with verbally, okay? Verbal and hearing are connected. So if they're not talking right or not enough, first thing, we're going to do a hearing evaluation. It could be hearing loss as younger, or maybe, later on with ear infections, etc. Now they've damaged their ears. So making sure problems with speech, think about a hearing evaluation. Now we think of kids in the hospital that they're not going to get decubitus ulcers and foot drops and all of those things. Well, yes, they do. You have a child who, for whatever reason, is in the intensive care, intubated, and we have to turn them, position them, and keep their skin and their body moving the way it should. So what do we do? Well, number one, if you don't have good nutrition, you're going to have skin breakdown, just like adults. Same thing with children. So good nutrition, whether giving them a tube feeding, whether giving them hyper-Al, whatever it is, good nutrition. Also, their skin will shear off like an adult because of long-term, when they're sick, in an intensive care like that. Draw sheets to pull them up. You pick them up and move them, put them down. If you start shearing them across the bed, you're going to have skin peeling off. Skin moisturizer, keep it nice and moist, but keep it dry like diapers. So younger kids can have diapers. Older kids, you might take and put a chucks underneath and then change that as we need it. Again, turning them over every 2 hours. And of course, using all the pressure reduction surfaces, equipment, the beds, the egg crates, so whatever it is that we use to get a nice soft bed to keep that skin from breaking down is what we want. We think that only adults get these, the sacrum is the cubitus. Well, you can in a child too. So taking care of a kid in a hospital, getting an assessment, whether in urgent care, an ER, hospital, doctor's office. Number one, you've got to make sure that kid's comfortable before you start, which means where are they with the least stress? If it's sitting in mommy's lap, they're going to be sitting in mommy's lap, and you're going to do your assessment from there. Again, get below them, never sit above them, break open the ice, talk about the cute little eyes or ooh, the cutie little cheeks or oh, I love your shoes, whatever it is. Get on their level, making sure you explain in a manner that they do understand, okay? I've seen kids older than 24 months on parents' lap. I've seen them 5 years old, depending, on that child. Always in the hospital when you get them, have the parents, again, especially your younger kids, toddlers, preschoolers are the two ones, mostly toddlers. Keep on the same routine, keep parents there, because what is the biggest area of stress, the greatest source? It's separation of the parents. So as much as possible, we don't separate them anymore. Now, there is sorts of play that we use, and we use these sort of plays in order sometimes to teach what's going to happen. Like it looks like that child's going to the OR. Yeah, I see syringes and needles and, stethoscope and a hat on his head. That's what doctors will be wearing. So now they're not as scared of it, right? So that's, it's telling you what's going on. Now, one of the things that happens in the hospital is something happens when kids get scared. And we need to figure out why. And sometimes they can't describe it to you, but play is non-threatening. So we can have them reenact what happened. Was it something that happened in an x-ray? Was it something happened with an IV start? We're going to have that child reenact what made them afraid, and they will show it to you, okay? And creative, draw a picture. Tell me what happened. Tell me how you feel. How was that IV start? How did you feel? All of these things help the child adjust to hospitalization and keeps them stress-free. Now, a child who's in pain, or an adult by any matter, if they're in pain, they're not going to do what they need to do, for instance, for post-op care. You have a child who's had surgery, whatever type. whether it's cardiac, whether it's abdominal. If they're in pain, they're not going to cough, deep breathe, turn position, get out of bed, and ambulate, right? So, number one, medicate them. And when you medicate them, you can do all of those things. And remember, medicating for pain isn't just the medicine, it's those distraction techniques, it's elevating heads of bed, repositioning, heat, cold, giving them a pillow for their tummy, whatever it is, we can help that pain get less by medicating them and then taking their mind off of it. All right. And I'll say it more than once, but if something's going to hurt, let the child know. I'll do everything we can to make it as little as possible. You want me to hold your hand? And many of them will say yes. And then you, as you're holding their hand, are going to do something to distract them as they're doing whatever that procedure is, if you can. So, variations in care. An IV on an infant is different than an IV on an adult. If you're seeing swelling, redness, pain, anything on a dressing, number one, on an infant and young kids, stop it. 20 mLs of fluid on an adult is nothing. 20 mLs on an infant blows up an entire arm. Okay. So what do? When an IV looks infiltrated, it's doing all of those signs of it. Stop it, elevate it, call the doctor. And if we need to get a new IV, then we'll get another one. Oxygen. Now, infants born, a lot of them come out with something called TTN, transient tachypnea of a newborn. And it's just they need a little bit of oxygen until their lungs get used to breathing. So, what would be the best way for this child? They're not in need of full intubation or CPAP or any of that. They just need a little bit of oxygen in the air. The oxygen
Sorry. What
is
was TTN again?
transient tachypnea of a newborn. It's like every now and then they go, and then they slow down,
Thank you.
and they slow down. Probably of all the respiratory things in newborns, it is the most common. You're full of fluids. They come out, they get rid of it, and you have to breathe. So it does happen. So oxyhoods, best thing. The kid can look around, suck on his fingers, on a passy. It's wonderful. And even nasal cannulas, they stick their fingers up. It's usually taped to their skin. They rip their skin. So oxyhood. Now, drawing blood on an infant. Unless you're doing a blood culture or bleeding coagulopathies, you can do a complete electrolyte panel, CBC, on these infants. And those two things is 1.2 mLs of blood, hardly anything. So, how do we do it? Well, you do it on the side of the heel. And the reason why we don't do in the middle, that's the calcaneus bone. And if you use one of the lancet that's too big, it will go in and hit the bone and cause osteomyelitis. Okay. So, number one, get a hospital approved heel warmer. It will dilate that area. And then you're going to put the heel down lower than the heart and very slowly squeeze it after we hit the side with that little lancet. Okay. And we can get as much as we want out of it. And if you take your time with it, you're not going to bruise the heel and you get as much blood as you need. Remember, with infants, remember, they don't have immune systems. So if they need urine because suspected infection, they're running fevers, you want an accurate urine specimen. It is not a bag. That has all skin contaminants in it, and you'll end up treating it 3-4 times with different antibiotics because you didn't get it right the first time. Infants don't have that. They can't be going through all of those infections. It could kill the kidneys, right? So do a straight cast. Parents don't like it, but when explained that then we can get one antibiotic, get it cured, instead of fighting this several times, they'll say, okay. And again, have the parents there giving them the pacifier or even breastfeeding during it, I've seen done, and it works well. So family-centered care, separation anxiety. big, big thing, right? We know that toddlers are the ones that really suffer with separation anxiety. The biggest stressor is separated from their parents. You know, separation anxiety has 3 stages. It starts with a kid, the parent has to leave for, they have other kids, they got to go to work, whatever the reason. And they cry, 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 cry. Then they go through a stage where they just regress, start sucking their thumb. They could even become incontinent. And then they realize, well, mom and dad has to go. So when they come back in the room, they'll ignore them. That's the 3 stages of separation anxiety. I mean, if we can, at all possible, always allow the parent to stay in the room with the child. And this is most aware that we should do that for that difficult temperament child. And they say males more than females. And they're talking somewhere between 5 months to 6 years. About 5 months, they start realizing mommy not being there. And of course, cognitively delayed, they don't understand why mommy's gone. So that would be one that we would really want them there. And again, same routines at home. So as I said, developmental regression happens during hospitalizations. Remember that a kid who's 1 year old who should be walking, if they've been in a hospital for a month, they may not be there, but it's normal. We can catch them up. Children are resilient. Start physical therapy on them and get them walking, and they do really good. We know sometimes this during hospitalization, that regression, again, they'll be incontinent. They'll start using the potty. They want a diaper back on. This is absolutely normal. Sometimes they sleep all night. Now they're not. Again, this is all about stress. We know that young kids, that infants, older infants, toddlers, preschoolers, that were there, were happy. Mom and dad leaves. Recording. What happened with that? Hold on. Right now, I'm doing good. So I know that when we have children who are going through separation anxiety, and that's the second stage after they're crying, these children usually are happy and playing by themselves. Well, if mommy's leaving or has left, they're going to be more clingier, they're going to be crying more, they're going to be regressing more. And again, it's absolutely normal. And again, about the 5th time now, greatest stressor for children, toddlers, your older infants, and your preschoolers. I think toddlers and your cognitive delay is that separation from parents. Now, school-age children are a little older and they understand more. They understand parents have to leave. But remember, we need to try to keep their routine similar to home. If they wake up, they brush their teeth and get dressed for the day, that's what they should do, or change their jammies, whatever it is. Or what do they eat? Trying to get the same things if we can, if the diet allows. If they are staying longer periods of time, trying to get their schoolwork done. And remember, if we are giving a school-age child something to play with in the hospital, make sure that we give them something that will challenge them, but they're able to accomplish. Because remember what Erickson says, that industry is what they do well. That would be that chore that what you have them doing. Maybe it's building a puzzle. You have them, it's a little difficult to get there, but they can do it. And if they can't, it's the inferiority, and you don't want them frustrated, okay? That's how an Erickson plays here. Otitis media. Otitis media are because there's narrow, short, open eustachian tubes, and mucus goes areas of least resistance, which is up into the tubes. And now you have an otitis media, okay? Now, what is the priority? You get a kid in, whether they're juicing out of their ear, it's ruptured already and all of that mucus has come out, or they're just in there and pain, pain, pain. What's the priority? Well, many of you would say an antibiotic, and the answer, no, it's not. Antibiotics will take 24 to 48 hours to work, so the pain's still there. So number one, get a kid complaining of pain. This ear hurts. Get them something. Acetaminophen is perfect for it. Ibuprofen is perfect for it. Whichever one they want, please give it to them. We know that that is your priority. Make them comfortable. And in 30 minutes, they're going to be running around and looking like they're not sick at all. It's really quite remarkable. We know that there's antibiotic drops for the externa, and we know oral is given for those otitis media. It's a staph infection. It needs antibiotics for sure. If you're having chronic ear infections, they're going to put tubes in. It's a surgical, it's an outpatient, in and out, to try to get that drainage moving. Now, our goal is preventing otitis media, right? So again, washing hands, not just us, children and parents too, right? And then getting immunized. Immunizations are one of the biggest ways to prevent it. And no cigarette smoking, no smoking around children. That actually, the smoke creates ear infections. Now, bronchitis. So we have an upper airway and we have a lower airway, right? Upper airway bronchitis is the tracheal and the bronchus are inflamed. Bronchitis is a non-productive, dry, hacking cough worse at night. It is annoying. You cannot sleep. And what is, you just treat the symptoms, okay? As in a cough medicine, a cough drop. That is what and how we treat them. The problem is it's at night and these kids can't sleep. Many a times it is a viral. Sometimes you might see a bacterial on them. Laryngotracheal bronchitis, croup. This is the one that they sound like a seal barking. It is loud. Um, it is usually caused by a viral thing. Could be RSV, could be flu, could be any of those things, any viral upper respiratory things. And what you see is a low-grade fever. One second. So with croup, you might have a little low-grade fever, like 100 and a little bit, but you'll be hoarse because it's inspiratory. Everything upper airway air is getting in. So that's inspiratory. You're going to have that working of respiratory, right? Also, you're going to see abdominal breathing because that compensates for the difficulty in breathing. It's just what the kids do. So we know that if a child has croup, is barking, and has that inspiratory stridor, they do need to get care. And literally what they treat it with is a little bit of a steroid, whether one shot, one pill, or one pill twice a day, 3 days in a row, all different from, but it is steroid. So that croup, that barking, what's going on? How do we treat it? And the abdominal breathing. So let's say it's getting pretty bad. There is a little YouTube channel there. You can listen to it. It's quite impressive. So how do we treat croup that's really getting that abdominal breathing and it's working really hard? Now you can't swallow secretions. It's all swelling up here. So number one, you want to maintain an airway. It's always airway, airway. And of course, if it's continuing, you want to maintain hydration. Are they still able to drink? Or no, we need to put it IV. Nebulized O2 really works well. This is like going into the bathroom, closing the door, sitting on the toilet and watching the heat of the shower and that moisture getting in. That's that nebulized mist too. And we can treat it also, depending if it's really bad, with epinephrine and an aerosol that goes directly where that swelling is. If croup, upper airway, laryngotracheal bronchitis continues, what happens is the swelling also swells the epiglottis. Now, remember the epiglottis is that leaf-like structure that covers the trachea when you swallow so that your food doesn't go in your lungs, it goes down your esophagus. So this child is going to look like an old person with COPD who can't breathe. Tripod position, leaning forward, but they'll be drooling. They're not going to cough, okay? Their speech is extremely muffled, and they're getting very little air in. So you're going to see them getting more and more agitated and confused, okay? So one of the ways to prevent it could be giving the Haemophilus influenza vaccine. And again, that's another immunization. That's why we give it, to prevent these sort of things. But what is your goal? You get a kid sitting forward, drooling, can't talk, garbled speech going on, and you see them working hard stuff going on. If you have that much here, that's actually a lot. You make sure that you get somebody to get emergency airway equipment at bedside, tracheostomy tray, intubation tray, because they're already hypoxic. They're already working hard, and we need to get that airway open. If it closes out completely, then we'll have a way to get it open, okay? Put nothing in the mouth. No tongue blades, nothing, because it will increase the swelling, whether it is a tonsillectomy, whether it's croup, whether it's epiglottitis, anything. Keep your stuff out of the mouth. We don't want increased swelling. And they say anybody who looks in there should be someone who can intubate, okay? That's the only person. Okay, cystic fibrosis. If two parents have a trait, then it's 1 in 4 chance of, or 25% a child will have a disease. What is the first thing? Now, let's say we didn't know the child was going to have cystic fibrosis, or even had the possibility. Maybe it wasn't tested for whatever reason. One of the symptoms is what we call a meconium ileus at birth, which means this child is not moving his bowels within the first 2 days of life. This is one of the symptoms of cystic fibrosis. So what will we do if we see no stool? We're going to do what we call a sweat chloride test. And all it does, it measures the amount of sodium on the skin. These children ooze salt out of their body, okay? So sweat chloride test measures how much sodium is there. Because cystic fibrosis affects the pancreas and what it secretes to help in fat digestion, it is damaged. The pancreas is damaged. So diabetes is a common comorbidity. It means sometimes, maybe not initially, but down the line, we'll be checking their blood sugars, making sure, do they have problems with their pancreas, okay? And remember, if the kid is older, this is something it's not going to cure. This is something you have to treat daily. Adolescents,
Yeah, I have no control over that.
adolescents must
Aren't we supposed
take
to be there?
and be involved in their own care. So what do you see in cystic fibrosis? We have the lungs are full of thick mucus. I call them big petri dishes, waiting for bacteria to get in there and grow, okay? The other thing it involves, I said, is the pancreas. So now we have problems with digestion. So what are symptoms of this child? What would you see? Well, they're not digesting fat. Their pancreas isn't digesting it. So it's not digested. So fat and fat-soluble vitamins are going right through the intestines. Large, bulky oil, extremely foul-smelling stools that you'll see. That's called steatorrhea. Now, that are high in calories, right? We're not using it. So weight loss is going to be a part of it. So these children need high carbohydrates, high protein, and leave the salt in their diet because they're losing it like crazy. What would their lungs look like? Well, any breath sound that you can imagine they have. They are full of junk. Wheezing, rhonchi, dyspnea, cough. It could be after aerosols and chest CPT, you might get some production up there, but these children are in and out with upper respiratory infections. They even give the aerosols with antibiotics in it. So as I said, cystic, they need all the salt they can have in their diet. Keep it there, let them know. And again, high calorie, high carb, high protein diets. And they're losing all their vitamins, fat vitamins. So they're going to need some sort of supplement. Their lungs are going to need, because it's thick, tenacious, it's hard to expectorate. So we need to thin it. So we'll be giving mucus thinning medicines in the aerosols. Some of them smell like rotten eggs, actually, and it helps thin it. We'll be given hypertonic saline and, of course, bronchodilators. After we give bronchodilators, then we're going to give the chest CPT. And remember, these children usually get this before every meal and at night, like 4 times a day. So make sure we do the aerosol, we do the chest CPT before they eat, because they need every calorie they can, right? So we don't want them to vomit. And because of chances of infection, make sure they clean their tubing and masks every day, so that they're not going to, take yesterday's germs and give me again today. Now, this usually is one of your NCLEX questions, but this is one that, is the treatment and how to give those pancreatase enzymes. Number one is immediately before meals. This says 30 minutes, but it's right before you eat. And what it does, it helps digest the food better. Those capsules have these enteric coated beads. Don't crush them, leave them alone. Anything enteric coated, you can't crush, because that's what they want them to be, enteric coated. If it's the capsule, you can open it and you can sprinkle it around. It's not a problem. There is powder also that we can use instead of the beads. The only thing with this one is you have to rinse the mouth, just like some of the respiratory drugs. Rinse it, it prevents mucosal damage, teeth damage, and all of that. And I think the one thing that we do forget is to give them increased doses as they get bigger. Children can grow 10 pounds in a year, right? Now, did we increase the enzymes or not? So one of the things with cystic fibrosis is women, yes, can get pregnant. It is a high risk pregnancy, of course, because of nutrition and because of airway oxygenation. But men are infertile. I've done some research, and what it says is the vas deferens gets clogged with mucus, and the sperm cannot be given to the woman, so they can't get them pregnant. Now, what they say is if the man has a bilateral lung transplant, they are much apt to be able to father their own children. And many of them do it just to have that child. Tonsillectomies. These are something that you'll see come in, usually outpatient. So you'll do pre-op teaching, put them into the OR, bring them out, recover them, and now it's teaching them how to take care of themselves post tonsillectomy. Well, as they wake up, keep them on their side, because if they bleed, we don't want them swallowing it, because then they'll vomit. They take and literally just cut the tonsils and the adenoids out, and then they cauterize those areas. So there's just big scabs there. That's what's left. So you don't want them vomiting or coughing or putting anything in there to tickle those scabs, because they come off, they will bleed a lot. I've seen clots come out of a little 7-year-old girl, just bleeding. She went into hemovolemic shock quickly. So leave that mouth alone, right? So limit activity, avoid irritating or highly seasoned food. Now, fluids, cool fluids are great. Nothing red, because we want to make sure if it's blood, right? Now, younger kids don't like an ice collar, but older kids can tolerate it a lot better. So put it on the neck, it helps with pain. Those popsicles, ice chips, cold treats, whatever, jellos, whatever they like, let them have it. And they say after day 4, if they're still bleeding, call the doctor. And we know that these kids are going to have a sore throat. And the other thing that we tell them, if we see them swallowing, they're sitting there and they're swallowing. This kid is bleeding. That means they're swallowing blood. This is something that we need to tell the physician. Many times they're bleeding and they have to go back to the OR and recauterize those areas. So that is a big clue that's going on. Now, the eustachian tubes connect way back there, right? So older kids get swelling in the ears, like going up in an airplane, that pressure that occurs. So how do we relieve pressure in the airplane? Chew gum, or you open your mouth wide and try to pop your ears. Well, we do this older kids, ear pain, have them chew gum. It does work. And when we talk about getting your tonsils out, these are school age children, right? Remember, they have loose teeth. It's normal. They're going to lose all their baby teeth. So remember, that can be a risk for aspiration. Now, asthma. No. So in asthma, these children, it is a lower airway and it gets inflamed. And air goes in really well and it gets stuck. And you try to push it out and it's like expiratory. So upper airway inspiratory. That's all here getting air in. And then it gets to the bottom and then asthma, you can't get it out. So that is expiratory wheezing. So remember, asthma, it's this hacking cough, and you can't get your breath. And it's non-productive, and it's that expiratory wheezing, prolonged expiration. So it's a hyper-responsiveness in the airway due to whatever. Could be leaves, like if you have asthma, would you be out there raking leaves and you're like, I'm from New York. I used to love to rake leaves and jump in them and then put them on fire, right? Well, an asthma kid, you wouldn't do that. If you're allergic to grass, would you be rolling around in the grass or be around when they're cutting the grass? It's like these things we think that they would understand, but make sure that they are taught. So again, frequent cough, you lose your breath easily, you're going to be wheezing, that's prolonged expiratory phase. And remember, if you don't hear wheezing and this child is asthmatic, they're not breathing. That is a severe emergency, okay? So silent chest, absent wheezing is your priority. You should hear something. My husband had status asthmaticus and he was in the ICU for 12 days with it. And I kept him from being intubated, thank goodness. But in the worst moments of it, the expiration phase, at the very end of this pushing of air, all I heard was a little a little squeak. That is how bad it gets. There's no air moving. So rescue is what we give. It should help with the wheezing, right? So albuterol. Remember, children can't push in, breathe in, and hold it, get their medicine. So any kid who's asthmatic coming in, still complaining, and they're using their MDI, meter dose inhaler of albuterol, if it's not working, ask them if they have a spacer. How are they doing it? Because sometimes they're just not getting medicine. The spacer is great. You see this little kid on the bottom. It's a little mask with a little clear tube, and you put the dose in, push 1, 2 times, whatever the dose is, and they're going to get it in, and it's going to open up their airway, okay? One of the things that we teach our young asthma children, and we should use it on the adults too, is to be doing what we call a peak flow meter daily. And that's that upper picture. And it shows how much air is moving on a daily basis. And once they're well and doing good, we're going to get a number. And if we see that number decreasing, that's when we would start the albuterol aerosols to open up the lungs. So we can really keep control of it, okay? So with asthma, you have rescue, albuterol. You have something morning and night with a little bit of steroid in it, they call it. In children, it's called Pulmicort. In adults, you have Symbicort, Advair, Brio. This is the one you have to rinse your mouth with. These are that prevents that bronchospasm. And they now are giving children as young as 2, Singulair. And of course, using that peak flow. And they do recommend exercise to keep the lungs healthy, and swimming is the best choice. Hold their breath, go underneath. You're really giving yourself some good PEEP in your lungs. Now, RSV for me and you is a common cold. For children, they don't feel well, but for infants, it's putting a little bit of mucus in the nasal airway, and now they can't suck, swallow, and breathe. RSV, respiratory syncytial virus, is also known as bronchiolitis. You'll hear the names the same. Now, a normal, healthy infant with no other condition usually does okay with it. You suction the nose, and then they can eat and take their nutrition in. On a child, cardiac child, cystic fibrosis child, you don't want this kid to get any more problems with their lungs than what they already have. So we can get an immunization monthly called Synagis or palvizumab. And it's once a month, first year of life, from early spring to early winter to early spring. And of course, you always want to avoid people. And of course, you want to keep your immunizations up to date. That's part of it. Sometimes these kids will put them in a cool mist tent. Now, if they're older adolescents, they're not going to want to be underneath this plastic in this bed without mom or dad. So if that happens, you can just have the parent put that moisture in their face. They're still getting that moisture that they do need. So RSV is a virus. That's how we treat it. Does not need antibiotics. It's not going to do anything. Our goal is to clear the airway, let them breathe, and then in those immunosuppressed, compromised children, we want to prevent it with Synagis. Now, pneumonia. You can have viral pneumonia. You can have bacterial pneumonia. You can have aspiration pneumonia. Aspiration pneumonia is when we overfeed children or don't burp them, don't sit them up, and that could
Miss
be from
Stevenson?
food.
Miss Stevenson?
Another thing is with aspiration, it also could be that wonderful baby powder that smells so good, but it goes into their lungs, can hurt. Also, smoke. We should never smoke in front of a child for ears and now for pneumonia too, right? Now, viral pneumonia is like an upper respiratory. It's a viral disease. How do we treat it? We're going to give antipyretics to take care of the fever, the aches and pains, make them feel well. Because they have fevers, we want to make sure they get plenty of fluids and just rest. If it is bacterial, we will add an antibiotic, and augmentin is the drug of choice. Mononucleosis. This is also called the kissing disease, right? We say the teenagers are, who are you kissing? It's just because it does get transmitted around, sharing toys, sharing, drinks, etc. It is a virus again, Epstein-Barr virus. Epstein-Barr is when you feel tired and weak and you can't move. It's that sort of achy, veiny thing. That's what Epstein-Barr is, okay? Now, you're going to see with this mononucleosis, usually you have a swollen gland, probably a sore throat. You're just, you feel terrible, fatigue, fever, maybe a rash. This disease causes swelling of glands, but it also causes swelling of the liver and of the spleen. Now, the spleen gets big and it's like a balloon. And if the bellies are touched or hit in a certain way, it could burst and the child would die. So with this disease, it's a viral disease. We need to teach that these children need to protect their abdomens, no contact sports. I was telling my class about an ATV and a kid who was there the week before. He told them no contact sports, protect the abdomen. Oh, he had mono. And a week later, this child was admitted on a trauma helicopter, fell off an ATV, hit his abdomen, and he arrived dead on arrival. And I'll never forget him. He was 9 years old. So, how do we treat a viral disease? Rest, fluids, fever reducing medicines, right? And protect that abdomen. And they can't do PE in school if they're in school until the doctor clears them. All right, congenital heart defects. So, what would you see if your heart's not beating right? Well, if you don't have enough oxygen, your heart says, oh, let me beat faster, right? And the lungs say, oh, let me breathe faster. Let me try to get the oxygen around. So these things you would see start of it. You might see swelling around the eyes. You see a lot of it. And you would see these children that even infants is usually what we see the congenital initially, of course, you're born with it. You would see them not able to eat and they tire easily and they're not gaining weight and they'd be sweating. Sometimes in this congenital heart defects and in failure, you're going to see all of a sudden a sudden weight gain. Your heart's not beating properly, it's not squeezing through the kidneys, your urine output's going to decrease and you're going to gain weight. And that would be that sudden weight gain. And you would see them, the color of this child's not going to be all of that good. So you're going to see that fatigue, rapid breathing, poor weight gain. So what do you do? How do you take care of these children? Because yes, you can give them medicines, but still, these children still need nutrition. So small, frequent feedings. You can increase the type of calories in the formula. You know, normal formula is 20 calories per ounce. You can go up to 30 or more if you want. Even with breast milk, okay? And never ever feed over 30 minutes, okay? Congenital heart defects, we know we're going to be looking at the murmurs, and we're also going to be coarctation. Is it that pulse disparities? Coarctation, the upper extremities, the blood's going up, but it's kinked, it can't get down. So uppers are higher, and the lowers are going to be a lower blood pressure. Congenital defects, this is again out of the book. It was off of the PowerPoint that I send out. You know, increased pulmonary blood flow, anything that puts more blood on the right side back to the lungs, or that PDA, right, that goes from the body, goes back into the lungs directly. Coarctation is something that we see tested on, the disparities between the blood pressures. Upper is higher, lower is lower, simple as that. And remember, A means without. An atresia means there's no opening, and osis means that there's a narrowing. It will flow backwards. What's going on? Tetralogy of Fallot is your biggest tested of all of them. Tetralogy of Fallot, it's knee chest that we put them in. It changes that pressure in the belly and out of the chest, and it pops open the valve as part of it. And we know tetralogy of Fallot because the heart's going to have these moments, they're going to be on digoxin to try to slower and strengthen force of contraction and preventing those blue spells or tet spells. Now, tetralogy has what we call 4 different defects. So there's always an opening between the 2 bottom ventricles called a ventricular septal defect. The septum or septal is open, small, medium, large hole. It depends. They're all just a hole. Pulmonic stenosis, the valve that goes from the right ventricle to the lungs is narrowed. So now we know there's decreased blood flow. The aorta pulls over. That's what an overriding aorta is, just the way that it sits in the body. And then because when blood can't get to the lungs, the right ventricle stretches to try to accommodate. It can't go up, so it tries to stretch, and then it goes down. okay? As I said, they're most on digoxin. We know there's that tet spells. We know it's, first of all, if the kid is older, try to calm them down. That's always number one, and knee chest them. And if you see that upper picture, that's an older child who has tetralogy, who all of a sudden, when it happens, they just squat to their knees and it works. So that's tetralogy. PDA, think about, this is a place where we can get oxygen to the body where the heart isn't working right. So you need to get oxygen to the body and let that heart beat best it can. We have this patent ductus arteriosus. It sounds like a machine, like a washing machine. Chikoon, 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 chikoon. It's just like that. It's the way they hear it. What we do to keep it open after birth is we just replace the hormone that mommy produced to keep it open for fetal circulation called prostaglandins. And it increases oxygen saturation, and it helps the heart pump, and it also keeps blood flowing to the brain, so it prevents central nervous system involvement. Now, there's sometimes these infants that have to they have it open more premature, majority, not all, but it stays open, and there's no reason for oxygenated blood to go back to the body to get more oxygen. More doesn't make it better. It doesn't happen. It is what it is. So we can close it, and it's an IV 3-dose called indomethacin. And this is usually, you'll all of a sudden see the blood pressure, the bottom number will come back to normal, and you're going to hear that machine-like murmur start to disappear, and you can hear it as it goes. I've already talked about atresia stenosis. One of the biggest atresias is tricuspid atresia. No opening between the right and the atrium and the right ventricle. That one is one where you're going to need that PDA open to oxygenate. No blood's getting up into the lungs, right? Taking chest tubes out of children. Now, I've done adults, I've done children, so I know it hurts. So chest tubes are scary. And they usually are removed when they stop draining, somewhere between the second to third to fourth day, depending, after surgery. And older kids, they're scared. So again, get on their level, tell them it's going to burn a second, give them, medicate them, something for pain. Always look at their vital signs before and after that, the medication, right? And also, when they're done, make sure they clean that site, and we keep it just clean and dry and no powder on it. Some children's heart never get correct, and we can do as much as we want, but a lot of them will need a transplant. The greatest risk for these children is rejection. Infections we can give medicines for, but in rejection is the body says, no, I don't like it, and the body rejects it, and then they will die. Digoxin, remember how to give it, just like adults. You're going to be checking all the lab values and the heart rate. It does slower and increase the force of contraction. It's good. As I said, it's used. One of the things is tetralogy of below. You're going to hold it if that pulse is too low. And the only other thing you may see in an infant is if they're vomiting. You see an infant vomiting on digoxin, and you don't have a recent digoxin level, you're going to be checking that, making sure that it isn't dig toxic, okay? So if you see him vomiting, hold the dose, call the doctor. Post-cardiac cath. Now, once we see an echo, there's a problem, we're going to be doing a cardiac catheterization, looking for exactly what's happening. Remember, they go into the femoral artery and the femoral vein, big, big ones. So they go in, they look at it, find what they want, pull out the catheters, and they put on a pressure dressing. And they make sure that it stops bleeding before they come back to your room. Once they come back to the room, first thing you should check for is that dressing, making sure it's not bleeding. And if it does, you're going to hold it above with 2 fingers until it stops, and you're going to be calling at the same time. But first of all, direct pressure, and then call a physician. Um, those pulses will be slightly decreased because of those catheters. It's normal. Just document, make sure that they maintain hydrated. And infants are very susceptible to high and low glucoses. Sometimes they haven't gotten any glucose during the procedure. So you always check a blood glucose when they come back to see if they need something. Rheumatic fevers due to strep throat. There's 2 conditions. This is the first one. Rheumatic fever, you get a fever, you get this joint pain, swelling, joint nodules, rash all over. And you might even have this chorea, this irregular movements. And that's sometimes what brings them in to be treated. And they will ask, so have you been sick lately? And they say, oh yeah, I had a sore throat. And they said it was virus. Well, probably it wasn't. So how do we treat this? Long-term antibiotics and everything, even that chorea, that weird movements that's going on. The only thing that you cannot reverse is a heart valve damage, okay? That they're going to have to be treated by a cardiologist. There's nothing we can do once it's damaged. ITP, idiopathic thrombocytopenia. When you don't have platelets, you are apt to bleed. Many times you're going to see bruising, petechial bruising, nosebleeds is one of the things you might see, and it's usually due after an upper respiratory condition. So this is something that we need to put them on some bleeding precautions, because usually at first they're admitted just to work up to be sure. And we just give IVIG and anti-D antibodies, okay? That's how we treat them. And then we're watching that child for bleeding. No venipunctures. Are they bleeding out of their nose, their gums, their urine, their stool? Are they ecchymotic? Are they petechial hemorrhaging? What's going on? You'll be doing CBCs every day. Usually they'll pull them out of the IV that we're using for the IVIG and anti-D, okay? Pull it right to there, so we're not even sticking them again. And then steroids are given, especially if the platelets aren't coming up as quick as we could. So ITP has nothing to do with blood vessels. You don't need IV fluids. It's all about bleeding and giving IVIG anti-D. Types of anemia. Iron deficient anemia, most common of all, right? You're not getting enough iron in the blood. Who's most at risk for this? Toddlers who don't like to eat, not eating all of the iron-rich foods we like. Also, you have the adolescents who get a power bar and gets a bottle of water, runs out for the day and doesn't eat all day, right? Plus, I'm too fat, I'm overweight, I want to be skinnier, because body image. So those are your 2 groups, toddlers especially. So we know that many times diet can be changed. Eggs, whole grains, raisin, great sources of iron. Not all toddlers are going to eat that. So they might have to be placed on supplements. It is a liquid. Remember, the iron that's liquid, it's brown. It stains the teeth. So it starts to be broken down to be used in the body in the stomach acid. So only with orange juice, never ever with milk, never after meals, before meals. Okay? Megaplastic anemia is your B12 deficiency. You will be giving that B12 injections. And a lot of times we see that beefy red tongue on these children. And hemolytic is that GP-G6 thing where you take glucoses and the red blood cells homologize and they burst. Sickle cell anemia, we're going to go into that more. Again, it's sickle-shaped cells. African American or African descent. Cooley's anemia. And remember, there's 4 types of thalassemia, but when you're tested on it, they're always talking about the Cooley's of thalassemia. This is the cells, the rectangle, they burst. Iron and oxygen are spewed in there. And the way that we treat it is blood transfusions. And then aplastic anemia, white cells, so it's infection, hemoglobin, anemia, platelets, bleeding is a triple whammy there. And we treat that like leukemia. So sickle cell. Sickle cell is when your blood vessels bifurcate and you get a sickle cell that clogs the entrance to wherever the either side. And then cells coming behind back up and it swells, it gets hot, red, swollen, and extremely painful. That's a sickle cell crisis. What is it due from? The blood vessel is too small and cannot flow the blood cells down the bifurcation and can't move past that spot. So how do we treat it? Well, you can treat the symptom of pain. That's not first, but let's treat the cause, small vessels. So number 1, we're going to be giving IV fluids, dilate the vessels, put heat on it, and that's going to help stop that backup of cells there. And of course, you're going to give pain medicine. It hurts. It's like in the other hand. To prevent these things from happening, again, these children need to be hydrated. If they're out there playing sports, and they can, as long as they keep hydrated, okay? These children also need really good protein calories. Think about going up in a plane in a pressurized cabin. You're going to need to have extra fluid before you go in to keep the vessels open to prevent, right? To prevent those sickle cells. Exercise is good. Keep them moving, keep those cells, the muscles squishing, all of that blood all over the place is great. These children with the pain, make sure they take it before it gets extremely bad because it can, and they should rest as needed. HIV in children. HIV is caused by many different things. It's rape, sexual abuse, or it could be an HIV mother giving it through to their newborn baby. We know that the biggest thing with HIV is for us to boost that newborn infant's immune system with antivirals so that we can possibly stop them from getting HIV. We know that PCP pneumonia is the big number 1 thing that happens to them, but they also can get fungus on their tongue, that big white tongue that you can't scrape off, you think it's milk. How do you treat on an infant this fungus infection on their tongue? Well, nystatin comes in powders and creams for diaper rash, but it comes in a liquid for the mouth. Take a swab it around the mouth and on the tongue, and it works, and it will help get rid of it. So again, HIV, your big thing is to improve that immune function. And we know we give those antiretroviral and antiviral drugs. And again, nutrition. Nutrition is always going to be up there with everything. And of course, trying to prevent any other opportunistic infections on them. Osteosarcoma, bone cancer. Remember, bone cancer, if it's in a bone, the whole bone has to go. You can't just scrape it off, or you can't remove a piece. So a femur bone has a bone cancer, the whole femur bone has to come out. That means knee to hip, all right? So what is the thing with osteosarcoma? Our goal is to save the lower leg, pick it up, turn it around, and put it in the hip. Why? We can put a prosthesis there, and now these children can be mobile. So bone cancer, it's remove the whole bone. Yes, sometimes it's a complete amputation, but our goal today, say salvage the limb on the bottom and have something there that we can work with to help these children be mobile. Leukemia. White blood cells are being attacked by cancer and they're made into something that doesn't work anymore. And you have no immune system. Down's children, again, are at higher risk than other children, believe it or not, poor Down's kids. We know they get chemotherapy, and we know there's 4 stages. The first stage of chemotherapy, they hit them with everything, whatever the 3 drugs are, 2 drugs, whatever the drugs, chemotherapy of right now are, the ones they find the best. And the goal is remission. But it doesn't mean that they stop there. There's 3 other stages looking for little hiding cells all over the place. So we're going to give antiemetics before, because they will get nauseous. They are going to lose weight, their hair. It's just part of it, and preparing these children what's going to happen. So they will do when you get the symptoms of leukemia. Usually it's fever, bone pain, bruising, tired, no energy, because you're white. With cancer, it eats red blood cells too. So they have no immune system, fever. They have hemoglobin hematocrits that are low, so they have no energy. Their bones hurt. They feel horrible. And they find that, yes, it is leukemia. They see those white blood cells. They're just not working. And their numbers could be 0.1 on admission when we first figure it out. A lot of these children need to get a bone marrow aspiration. We're looking at those cells, seeing what's going on. Again, it hurts. Yes, they put numbing stuff on top. They put numbing stuff going all the way down, but tell them it's going to hurt. Be honest with them. And we know some children may need a bone marrow transplant. Just the chemotherapy didn't work. The way you remember these names, autologous automatically mine's the best. So that could be your cord blood that has been saved, right? That's you giving me myself my own stuff. Automatically, mine is the best, autologous. Now, allogenic is all the other people. What is the other person that is best next to you? Your sibling with the same mother and father. But you don't have to have the same blood type, anything. Could be from anybody, not even related. But this is how you remember the name. Automatically, mine is the best, autologous, all the others allogenic. And infection is the biggest complication of stem cells. Now, we talked about neutropenia and low neutrophil count. And it doesn't matter if the child is with cancer, getting chemo, or a normal child who has an infection, raging infection going on. Neutrophil counts that we see less than 500 means there's no immune system. If you're given a group, a scenario, priority, who do you see first of this, and this child? Someone with neutrophil count of really low with a fever is your priority. They will get septic shock and they will get it quick because there's no anything to fight for them. Now, Hodgkin's lymphoma and non-Hodgkin's lymphoma. Now, there's always a question on it, and 50% always get it wrong. So I've come with a new way for you to remember. Hodgkin's lymphoma is like a lodge, your house. You can see it, feel it, touch it. It's big. They're enlarged, firm, non-tender, movable nodes. And these are supraclavicular, means above the shoulder. You see their necks sticking out with these big things. And it squeezes on the airway so you can have a cough. You can see why. It's taking up space. Non-Hodgkin's, not a house, means I can't see it. They're diffuse. They're all over the place. Okay? That's the difference. Hodgkin's and non-Hodgkin's. Treatment, just about the same. Chemo, doing biopsies, and chemo and eradicating them. So let's look at now tumors, in the brain tumors. Now, a lot of the tumors are in the brain. What would you see? because it's not like they say, I feel a lump there. It's inside. So what would you see? You're going to see a kid who's not acting the way they should, maybe falling over, but headaches that are becoming worse over time. And vomiting, not related to eating. Okay. Those are your big things that you're looking for. And what they'll do is radiation, shrink it, make sure you never wipe off all those purple marks, because that's where that radiation goes into, and chemotherapy. And then they go and they take it out, the tumors. Wilms tumor is a renal or a kidney tumor. You'll hear it called renal and you'll hear it called kidney. Nephroblastoma is what it is. And the big thing about these tumors, they get quite large, but if you manipulate them, touch them too much, little pieces will break off and it won't metastasize easy. So on the bed, on the chart, stamped on the forehead if you should, do not palpate the abdomen, okay? You don't even do a biopsy on these because it opens up a space for that cancer to get out. They just go in, chemo, radiation, they go down and they take it out. Always remember CPR, always review it. There'll always be some sort of question. Do you start CPR? Do you call the code? These are things that you need to look at, okay? And that is the algorithm there. Always know there's dosage calc. If anybody needs help with it, I'm always available for you. Just, ask me. I've got some great tutorials on my Professor Bogart YouTube page. Just look at them. I make it easy, even if you do dosage calc. I wish you all the best. And I know that this test is going to be better than the first one for you. Any questions?
No, I'm good. Thank you.